Today we are going to talk about uveitis versus glaucoma in dogs, two painful, vision-threatening disorders that may both produce a red, cloudy, squinting eye but usually have opposite effects on intraocular pressure. Uveitis is inflammation of the vascular middle layer of the eye, including the iris, ciliary body, and choroid. Inflammation disrupts the blood-aqueous barrier, allowing protein and inflammatory cells to enter the anterior chamber and create aqueous flare. Prostaglandins produce miosis and painful ciliary muscle spasms, while inflammation of the ciliary body commonly reduces aqueous humor production and lowers intraocular pressure. Potential causes include trauma, lens-induced inflammation associated with cataracts, immune-mediated disease, tick-borne infection, systemic fungal disease, bacterial infection, neoplasia, and idiopathic inflammation. Glaucoma develops when aqueous humor cannot drain from the eye fast enough, causing intraocular pressure to rise and damage the retina and optic nerve. Primary glaucoma is commonly associated with an inherited abnormality or narrowing of the iridocorneal drainage angle. Secondary glaucoma may develop from chronic uveitis, lens luxation, intraocular neoplasia, severe cataracts, hemorrhage, or previous ocular surgery. Acute glaucoma can destroy vision rapidly, making it an ophthalmic emergency. Diagnostics begin with a complete ocular examination. A normal Schirmer tear test in dogs is generally around 15 to 20 millimeters of wetting per minute. Fluorescein staining should be negative unless a corneal ulcer is present, and it must be performed before topical corticosteroids are prescribed. Tonometry is essential. Normal canine intraocular pressure is commonly around 10 to 25 millimeters of mercury, although the device, breed, time of day, stress, and restraint technique affect the result. Uveitis commonly produces pressure below the normal range, whereas persistent readings above approximately 25 to 30 are concerning for glaucoma. Pressures around 40 to 50 millimeters of mercury or higher require emergency treatment. Both eyes should always be measured for comparison. Gonioscopy evaluates the iridocorneal drainage angle, while fundic examination assesses the retina and optic nerve for degeneration or optic nerve cupping. Ocular ultrasound is useful when corneal edema, cataracts, hemorrhage, or severe inflammation prevents visualization of the posterior eye. Bilateral or unexplained uveitis may also require a complete blood count, serum chemistry, urinalysis, blood pressure measurement, infectious disease testing, thoracic imaging, or abdominal imaging to identify systemic disease. For non-infectious anterior uveitis without a corneal ulcer, prednisolone acetate 1% or dexamethasone 0.1% ophthalmic medication may be administered as one drop approximately every 6 to 8 hours. More frequent administration may be needed for severe inflammation under veterinary supervision. These corticosteroids reduce inflammatory mediator production and help restore the blood-aqueous barrier. They must not be used over a corneal ulcer because they delay healing, suppress local immunity, and increase the risk of corneal infection or melting. Atropine 1% may be administered every 12 to 24 hours to effect. Atropine blocks muscarinic receptors, dilates the pupil, reduces painful ciliary muscle spasm, and helps prevent adhesions between the iris and lens. It must be used cautiously and discontinued if intraocular pressure becomes elevated because pupillary dilation can worsen impaired aqueous drainage. Severe non-infectious uveitis may require systemic prednisone at approximately 1 to 2 milligrams per kilogram, but infectious causes should be investigated before immunosuppression. Confirmed fungal, bacterial, or tick-borne disease requires appropriate organism-specific antimicrobial therapy rather than corticosteroids alone. Acute glaucoma treatment is intended to lower pressure immediately. Latanoprost 0.005%, commonly administered as one drop every 12 hours, increases uveoscleral aqueous outflow and produces intense miosis. Lens position must be evaluated first because miosis can trap a luxated lens and worsen pupillary block. Latanoprost may also aggravate active uveitis. Dorzolamide 2%, generally administered as one drop every 8 hours, inhibits carbonic anhydrase within the ciliary body and reduces aqueous humor production. It may sting and cause conjunctival irritation. Timolol 0.5% every 8 to 12 hours blocks beta-adrenergic receptors and further reduces aqueous production, but systemic absorption may cause bradycardia, making it a concern in small dogs and patients with cardiac disease. During a severe acute crisis, mannitol may be administered at approximately 1 to 1.5 grams per kilogram intravenously over 20 to 30 minutes. It increases plasma osmotic pressure and draws water from the vitreous. But hydration status and renal and cardiac function must be evaluated first. Visual eyes that cannot be controlled medically may require laser cyclophotocoagulation or a drainage implant. A permanently blind, painful eye may ultimately require enucleation to provide lasting pain relief. The simplest distinction is that active uveitis usually produces a small pupil and low intraocular pressure, while glaucoma commonly produces a dilated or poorly responsive pupil and high pressure. However, chronic uveitis can obstruct aqueous drainage and eventually produce secondary glaucoma. If you have topics you would like to suggest, reach out to @doggersgame or dogtoursgame@gmail.com.